Jean-Luc Monin will present how to assess a patient with aortic stenosis using echocardiography. He will start by examining the aortic valve morphology and mobility and the extent of aortic valve calcifications. Afterwards, he will show the different steps to assess the aortic stenosis severity, including the windows and the measurements to get the left ventricular outflow tract diameter, the recordings of the LVOT flow and the transvalvular aortic flow, as well as the presence and extent of left ventricular remodeling.
We will now perform the echo of an old lady. She's 91 years old with a calcified aortic stenosis. And this lady is really symptomatic because she has NYHA class 3 dyspnea with also some chest pain during exercise. So, as usual, we will begin with the parasternal view. And here, the first view on the parasternal long axis shows that the aortic valve is calcified and with also a calcification of the left ventricular outflow tract and a very limited opening of the valve. We still perform the M-mode measurements that confirm that there are heavy calcification within the aorta and with the diameter of the valsalva stenosis at 32 millimeters, which is normal, and a mildly dilated left atrium at 52 millimeters of diameter. Then we will perform the M-mode measurements of the left ventricle. We will try to have a perpendicular axis as compared to the left ventricular long axis for these measurements. And here we can see that the interventricular septum is 15 millimeters of diameter at end diastole, and the posterior wall is 20 millimeters of thickness at end diastole, with the left ventricular end diastolic diameter at 50, which gives us a thickness to left ventricular ratio at 0.51 and a left ventricular mass highly above 130 grams per kilo. So this patient has clearly concentric left ventricular hypertrophy. Then we go one intercostal space upper to image the aortic root. And as usual, we will take the measurements in diastole from leading edge to leading edge. And as you can see here, the valsalva sinuses measure 34 millimeters, with a sinotubular junction at 31 and a tubular portion at 36. All these values are within the normal range for this patient. Again, we go to the longitudinal view of the outflow tract, and we will use the zoom mode to measure the outflow tract diameter. It's better to say that we will measure the virtual basal ring of the aortic valve, and the measurements is opposed to the technique that we used formerly to measure the aortic root. In this case, we will measure in systole with the valve opened, and we will measure from inner edge to inner edge and parallel to the plane of the valve. Here we have one first measurement at 24 millimeters, a second measurement around 22. We cannot underestimate this measurement by echo. Clearly, this is rather underestimated as compared to CT scan, and we will finally take the value of 23 millimeters for this virtual basal ring diameter, which will be used for the calculation of the aortic valve area by the continuity equation. Then we move to a transverse plane to have an en-face view of the valve, and as you can see, the valve is heavily calcified. We can also see the ostium of the right coronary artery. The opening of the valve is severely reduced here with a calcium node on the right coronary cusp. And we will also image the left ventricle on this transverse view, which again shows that there is a severe concentric hypertrophy of the left ventricle with a small pericardial effusion here in this patient who is probably in a state of heart failure. Now we move to the apical views, and again in this four-chamber view you can see that the myocardium is severely hypertrophied and that the ejection fraction seems preserved. Afterwards, we move to the two-chamber view again. That gives the impression that the ejection fraction is preserved, but we will see afterwards that the longitudinal function in this patient is severely impaired in contrast to the ejection fraction, which is preserved. And here, the three-chamber view enables to check that there is no subvalvular obstruction, and you can also see that there is heavy calcification at the valvular level, but also at the junction between the aortic valve and the mitral valve, and in the outflow, in the left ventricular outflow tract. The color Doppler shows that there is almost no aortic regurgitation and a very trivial mitral regurgitation. We will go back to the four-chamber view to check the mitral inflow, and here we have the measurements of the E to A ratio with an E wave of 0.89 centimeter per second. We will compare this to the E prime wave measured with the tissue Doppler here on the lateral part of the mitral annulus. And here we have the E prime, the tissue Doppler, the pulse tissue Doppler of the mitral annulus with an E to E prime ratio at 15, which supports high left ventricular filling pressure in these patients. Then we will move to the tricuspid valve to measure the tricuspid regurg peak velocity to assess the systolic pulmonary pressure. And we have a peak gradient on this tricuspid regurg of 35 millimeters of mercury, which probably gives a peak systolic pressure of 45 to 50 millimeters of mercury, probably mild systolic pulmonary hypertension. Now, importantly, we will move the probe to change the long axis of the heart and to be parallel not with the long axis of the heart, but with the ejection, the outflow tract. And this is to have a real parallel alignment with the Doppler beam. And here we will place the pulse Doppler sample volume within the outflow tract between 5 millimeters and 1 centimeter above the valve. And here we will progressively move the sample volume towards the valve to go right in the turbulence region. And when we have reached this turbulence region, we stop here the image and we go back with the Cine loop to the highest velocity that meet the criteria of laminar flow here with a nice slope. And we take a first measurement with this automated system. Here we have a LVOT time velocity integral of 23 centimeters. We take several measurements that confirm that this time velocity integral is preserved at 23 centimeters which gives a left ventricular stroke volume at 95 millimeters, which is strictly normal. On the same view, with the color Doppler, we can check that we will be parallel to the transvalvular flow here, you can see. And we will use the continuous wave Doppler to record this transvalvular flow with the dual probe. Afterward, we also can use the PEDOF probe, but currently, in my experience, we have the same values with the dual probe as compared to the Doppler probe. Here we have a first measurements with very high transvalvular peak velocity at 5.6 meters per second. That gives a mean pressure gradient of 75 millimeters of mercury and a valve area of 0.6 centimeters square. We can make other measurements that will confirm this very high gradient aortic stenosis with, again, 5.6 meters per second of peak aortic jet velocity, 76 millimeters of mercury for the mean gradient, and again 0.6 centimeters square. We can check the left ventricular systolic function by the ejection fraction, which is preserved. Here we have a measurement with a biplane Simpson methods that gives an ejection fraction of 53%, which is within the normal range. But if we check the longitudinal function, segment by segment, we can see that on the basal segment of the left ventricle, we have very low longitudinal function with a peak strain of less than 10% in the basal segment of the septum here, and a peak longitudinal strain here around 8% on the medial segment of the septum, in contrast to the apical segments where the longitudinal function is relatively preserved with a peak strain around 16% here. Now we will move to the right parasternal view in this patient. The right parasternal view is very useful to image the aortic root and to record the peak velocities in case of aortic stenosis. The position of the probe is with the same axis as compared to the parasternal longitudinal view, but on the right side of the sternum. And here you can see that we have a nice image of the aortic root with the aortic valve here calcified, and as you can see, the flow is nicely parallel to the Doppler beam, and if you use the continuous wave Doppler, you have this very nice peak velocity, even higher as compared to the apical view at 6 meters per second with a mean pressure gradient of 95 millimeters of mercury, mean pressure gradient, and a valve area of 0.5 centimeters square. So in conclusion, for these patients, we have a critical aortic stenosis defined by a peak aortic jet velocity higher than 5.5 meters per second and a valve area lower than 0.8 centimeters square. The left ventricular ejection fraction is preserved in contrast to longitudinal function, which is impaired in the basal and middle segments, probably due to fibrosis. And in these patients who is symptomatic at 91 years old, we will discuss the best management between classic open chest surgery and transcatheter aortic valve implantation.
So what are the key messages of these examinations? When assessing aortic stenosis severity, you must use multiple acoustic windows, and you must report 4 features: the stroke volume, the highest transaortic velocity, and the windows to get this velocity, and the aortic valve area.